Hi, I am Mr. Lakshan. Welcome to today's topic, Intrauterine Growth Retardation. So, what is IUGR? That is the condition of fetus at or below 10th percentile of its weight gestational age curve that can be identified by a newborn not attained the normal growth. These infants are disadvantaged before enter the world. The causes can be maternal, fetal, placental, and genetic factors. The primary cause of IUGR is widely considered to be placental insufficiency. For example, inability of the placenta to adequately support fetal growth. The maternal risk factors are diabetes, high BMI, and hypertension. These risk factors can be caused to high and low income settings. When we talk about maternal risk factors, maternal age less than 16 years or more than 35 years affect on fetal weight, and socioeconomic level, maternal substance abuse like smoking, both active and passive, affect on fetal weight. Moderate to heavy physical work during pregnancy also affect the weight of the fetal. Interpregnancy interval less than 6 months or 120 months or more also affect the fetal weight. And the placental causes are placental weight less than 350 grams and multiple infarctions, single umbilical artery, calcification in placenta, partial molar pregnancy, multiple gestation, placental dysfunction also affect the weight of the fetal. And the next category, fetal factors, chromosomal abnormality, genetic syndromes, major congenital abnormalities, metabolic disorders, multiple gestation, congenital infections also affect the weight of the fetal. Look at the pictures. Can you identify the two types of IUGR? Here, first one is symmetric IUGR. In symmetric IUGR, the size of the head, body weight, and length are equally reduced. The causes include genetic and chromosomal disorders or torch infections. Next one is asymmetric IUGR. Here, head circumference is preserved compared to length and weight. The causes for asymmetric IUGR can be placental insufficiency, pregnancy-induced hypertension, or maternal malnutrition. So, guys, we can identify IUGR by Pondrial index. In Pondrial index, we can use to identify infants whose soft mass is below normal for the stage of skeletal development. The Pondrial index is arrived at by the following formula. A Pondrial index below the 10th percentile may be used to identify intrauterine growth retardation infants correctly. This can affect the long-term outcome. Thus, all IUGR infants may not be small for gestational age, and all small for gestational age infants may not be small due to growth restrictive process. A low neonatal Pondrial index is defined as less than 1 standard deviation below a mean 2.0, and small for gestational age is considered as birth weight below the 10th percentile. Fetal Pondrial index can also be calculated by ultrasound examination. Now let's see short and long-term complications of IUGR. These IUGR neonates face numerous short-term complications after birth and includes perinatal asphyxia, meconium aspiration syndrome, persistent pulmonary hypertension, hypothermia, hypoglycemia, hyperglycemia, hypocalcemia, polycythemia, jaundice, feeding difficulties, feed intolerance, necrotizing enterocolitis, late onset sepsis, and pulmonary hemorrhage. These IUGR infants need long-term follow-up as they are prone to develop many complications when they become adult, like poor physical growth and small height in adulthood. The IUGR infants, because of in utero epigenetic modifications, are more likely to develop developmental origin of health and diseases in their adolescence and adulthood. These infants can also develop subtle to major cognitive and neurodevelopmental abnormalities. The common neurological problems encountered in these children includes lower scores on cognitive testing, school difficulties or requirement of special education, gross motor and minor neurologic dysfunction, behavioral problems like attention deficit, hyperactivity syndrome, growth failure, lower strength and work capacity, cerebral palsy, low social competence, poor academic performance, lower intelligence, hyperactive behavior, poor perceptual performance, poor visual motor perception, motor incompetence, reading and mathematics learning, low weight when become adult, had high prevalence of syndrome X, coronary heart disease, diabetes mellitus, hyperinsulinemia, and hypercholesterolemia. This was known as fetal origin of adult disease, and recently this term FORD has been replaced with developmental origin of health and disease. The three different hypotheses proposed for this cause relationship are fetal insulin hypothesis and Modi genes, thrifty genotype and thrifty phenotype. Barker's hypothesis. The Barker hypothesis is the most accepted theory for Doehead. These IUGR infants are more developed number of adult disease in their lifetime. Now let's see Barker's hypothesis. Barker's hypothesis states that fetal life environment has a long-term effect on the postnatal life. According to this theory, when fetus is faced with adverse conditions in utero, the reason being maternal, placental or fetal, then the fetus undergoes various adaptations to survive in these adverse conditions. The various adaptations are cephalization, decreased synthesis and increased resistance to the fetal insulin and insulin-like growth factor, and upregulation of the hypothalamo-pituitary adrenal axis. These changes are called epigenetic modification, and these modifications take place during the critical time period of fetal growth, making them permanent or programmed in the genes of the fetus. These epigenetic modification with postnatal mismatch of nutrition, suboptimal daily habits, and infants' genetics and epigenetics makes these IUGR neonates to develop Doehead in adulthood. Prevention of IUGR. The intervention those are effective in reducing the birth of IUGR includes balanced energy protein supplementation, intermittent preventive treatment of malaria in pregnancy, multiple micronutrient supplementation, insecticide treats, nets, antiplatelets for preeclampsia, and smoking cessation. Intrauterine growth restriction is an important cause of neonatal mortality and morbidity. These neonates face many acute problems during peripartum and after birth. They are more likely to develop developmental origin of health and disease Doehead in adulthood that makes the regular follow-up unnecessary and needs the protocol for it so that any deviation of these IUGR neonates' growth from normal can be picked up early. I think all of you enjoyed this video. Thank you.